Thank you again for joining us for the program year 2021, Objective 2, Electronic Prescribing, Objective 3, Clinical Decision Support, and Objective 4, Computerized Provider Order Entry Open Forum. This presentation is provided through a shared commitment between Access, Health Current, and Myers & Stouffer to increase participation in the Medicaid Promoting Interoperability, or PI program. Just a few logistical reminders. Today is an open forum and will be recorded and posted on the Health Current and Access websites. We encourage you to use the chat box for questions. Please do put your name, practice organization. Do not include any confidential information such as patient health information or PHI. We are going to be muting all lines today, and just as a note, that chat box is a great way to ask questions throughout today's presentation. Connie, I'm going to turn it over to you.
All right, Christine, can you hear me?
Hello? I certainly can, Connie. I can hear you, Connie.
Okay,
thank you.
Very good. Okay, thank you, Christine. We're very lucky today to have Priscilla Clark, a manager with Myers & Stouffer, a certified public accounting firm that specializes in federal and state Medicare and Medicaid programs, is our open forum presenter today. Priscilla, proceed. Thank you.
Thanks, Connie. Christine, if you go to the next slide, please. Perfect. So for today, we will be having an open forum. So if you have any questions, definitely feel free to put them in the chat box or request to unmute yourself, and we can talk about any questions or concerns you may have with the program. This slide just kind of shows the changes from program year 2020 to program year 2021 and just what things specifically changed. So as you can see, it was mainly the reporting period. So the PI 90-day reporting period in 2020 could have been during the entire calendar year, January 1st through December 31st, 2020. Same thing for the CQM reporting period. However, for program year 2021, that did change slightly. And so your 90-day reporting period as well as your CQM 90-day reporting period must start and end between January 1st and October 31st of 2021. And then for the SRA completion date, in prior program years, 2020 and before that, the SRA must have been completed on or after the end of the PI reporting period and no later than December 31st, 2020. However, for program year 2021, the SRA must be completed within calendar year 2021 and no later than December 31st, 2021. So your SRA can be dated during your MU reporting period. Next slide. So this is just a general summary of the meaningful use requirements and what you're going to need to show when you attest for program year 2021. All EPs are required to attest to stage 3. They must have a 2015 edition cert. They have to meet 8 objectives, and the related measures must be met. Within those 8 objectives, there's 5 objectives that are considered percentage-based measures, and then 3 objectives are yes-no measures. Again, if exclusions are selected, the provider must meet the exclusion criteria, of course, and provide adequate documentation to show that they meet the exclusion. EPs must report on a minimum required number and type of CQMs. They must maintain at least 80% of all unique patients' data in Cert, and they must perform at least 50% of all encounters at location with Cert. In addition, of course, to meeting those MU requirements listed on this slide, the EP must meet all eligibility requirements of the program. There is a link at the bottom of this presentation that takes you to another webinar that was presented on behalf of Access and Health Current, and that's the documentation retention webinar, and it does provide examples and go into further detail about those those eligibility requirements. Next slide. And so as you can see, this table lists the 8 different objectives and identifies whether they're yes, no, or percentage-based measures. The 3 objectives that are highlighted, numbers 2, 3, and 4, that is electronic prescribing, clinical decision support, and computerized provider order entry, which we call Cpoe. We will be asking some polling questions throughout this webinar just to get an idea of y'all's understanding of the program and maybe to help even get you thinking about any additional questions or problems that might arise for your providers. As you can see in the far right column, there is the columns labeled resources. And it has a webinar for each of these objectives. So if you do want to do further research or just to see what requirements are out there for Program Year 2021, you can, once this webinar or this presentation is sent out to you, you can click on those links. It'll take you directly to those webinars that were presented on previously this past year. Next slide. So this is Objective 1, Security Risk Analysis, which I'm sure most of you are familiar about. If y'all do have any questions, definitely feel free to ask those in the chat box or ask to be unmuted, and we can talk about those questions. This is basically just the practice having to create a security risk analysis for the program year that they attest for providers. Next slide. For Objective 2, electronic prescribing, this is when the provider must generate and transmit permissible prescriptions electronically. So more than 60% of all permissible prescriptions written by the EP are queried for a drug formulary and transmitted electronically using Cert. Next slide. And keep in mind that there's just one measure underneath that objective. For this objective, for Objective 3, clinical decision support, which we refer to as CDS, this is where an EP must satisfy both measures for this objective through a combination of meeting the thresholds and exclusions. So there are two measures for this objective. Next slide. And we'll go over and ask polling questions for both of these measures. So measure 1 is implement 5 CDS interventions related to 4 or more electronic clinical quality measures at a relevant point in patient care for the entire PI reporting period. However, absent 4 ECQMs related to an EP scope of practice or patient population, the CDS interventions must be related to high-priority health conditions. Measure 2 that the provider must meet as well is to enable and implement the functionality for drug-drug and drug allergy interaction checks for the entire PI reporting period. Next slide. Objective 4, which is another objective we will be focusing on during today's webinar, is the Cpoe, which is the Computerized Provider Order Entry. For this objective, you need to use Cpoe for medication, laboratory, and diagnostic imaging orders directly entered by any licensed healthcare professional, along with a few other credentials for other employees that work for the practice that can enter in that data into the Cert. There are 3 measures for this objective. Next slide, and we will be going over each of those 3 measures. So an EP, through a combination of meeting the thresholds and exclusions, or both, must satisfy all 3 measures for this objective. As you can see, all 3 measures have a minimum threshold of 60%. These are percentage-based measures. For measure 1, it's in regards to medication orders created by the EP during the PI reporting period, and they are recorded using the Cpoe in the Cert. Same thing for measure 2, except it relates to laboratory orders. And then for measure 3, same type of requirements, except it relates to diagnostic imaging orders. Next slide. This is for Objective 5, which is patient electronic access. The EP provides patients with timely electronic access to their health information and patient-specific education. This objective has 2 measures, and an EP must satisfy both measures for this objective through a combination of meeting the thresholds and exclusions for each measure. Next slide. Objective 6 is coordination of care through patient engagement. So the objective is to use the Cert to engage with patients or their authorized representatives about the patient's care. An EP must meet the minimum threshold for 2 of the 3 measures or meet one of the 2 available exclusions. The exclusions for all 3 measures are the same. So if the EP meets one of the exclusions, the EP can meet the exclusion for all 3 measures. Next slide. For Objective 7, which is health information exchange, the EP provides a summary of care record when transitioning or referring their patients to another setting of care, receives or retrieves a summary of care record upon the receipt of a transition or referral or upon the first patient encounter with a new patient, and incorporates a summary of care information from other providers into their electronic health record using the functions of a Cert. An EP must attest to all 3 measures and meet the minimum threshold for 2 of the 3 measures. Next slide. Objective 8, which is public health and clinical data registry reporting. The EP is in active engagement with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using Cert, except where prohibited and in accordance with applicable law and practice. For the measures underneath this objective, an EP must satisfy 2 of the 5 measures for this objective. Keep in mind that if an EP cannot satisfy at least 2 measures, the EP may still meet the objective if the EP qualifies for exclusions from all measures the EP cannot meet. Next slide. And here's a list of the available registries in Arizona. As you can see on the left-hand side, it walks through each of the 5 measures that are available to providers, and then it also provides 2 separate different types of registries, potentially if available. As you can see, syndromic surveillance and case reporting. No registries are available to the EPs in Arizona, but EPs can still attest Immunization Registry, Public Health, and then for clinical data registry reporting, there are 2 links there that take you to a website that provides a list of potential clinical data registries that providers can attest to. Next slide. So what is electronic clinical quality measure? We've been referring to CQMs a lot throughout this presentation already. So CQMs use data electronically extracted from Cert and or health information technology systems to measure the quality of healthcare provider. The Centers for Medicare and Medicaid Services, which is CMS, use eCQMs in a variety of quality reporting and value-based purchasing programs. Hospitals, professionals, and clinicians use eCQMs to provide feedback on their care systems and to help them identify opportunities for clinical quality improvement. eCQMs are also used in reporting to CMS, the Joint Commission and commercial insurance payers and programs that reimburse providers based on quality reporting. Next slide. There are some definitions for the CQMs for the PI program. So EPs must attest to 6 out of 47 available CQMs. 6 of those are outcome measures, 27 are high priority, and then 14 are just the remaining measures. As you can see, the priority level 1 is you want the EP to meet that priority level 1 first. So if it's relevant to the provider, though, at least 1 CQM should be an outcome measure. If that is not relevant to the provider, then they should try to meet priority level 2, which is if no outcome measure is relevant, at least 1 CQM should be a high priority measure. And then, of course, for priority level 3, if no outcome or high priority measures are relevant, report relevant measures if possible. So CMS definitely wants the providers to attest to those CQMs that are relevant to the provider. Of course, that is not always possible, so that's why there's those 14 remaining measures that may be attested to. Next slide. We will now be discussing some just general polling questions to kind of get an idea of where you are in the program and what your interest is and your level of interest for each of the program years. So this first question is, has 2015 certified electronic health record technology been fully implemented at your practice? If you're using the text messaging, you can text A for yes, B for no, C for unsure, or D for it's not applicable to you. If you're using the website, of course, you'll just click on A, B, C, or D for the corresponding answer. I'll give y'all about 5 to 7 seconds to answer that. Remember, this is the first polling question, I'll give you a few extra seconds. So you can either go to the website and respond at pollev.com/EO-program753 to click on the appropriate answer, or you can text EO-program753 to 22333 to join, and then you'll just text the corresponding letter. Okay, it looks like everyone has your 2015 cert. Keep in mind that if you do attest to program years 2020 or 2021, which are currently open, you will need to make sure that 2015 cert is implemented at your practice. We can move on to the next question. Okay, so when do attestations for program year 2020 and program year 2021 close? So if you don't know the correct answer, definitely give your best guess. A is for those programs closed on July 31st, 2021. B is that they close October 31st, 2021. C is that the programs will close December 31st, 2021. D is that they'll close January 14th, 2022. Or E, you're just not sure. And this is referring to both program years because they both have the same close date. Give you a few more seconds to answer those questions. Okay, so B is correct. Both program years close on October 31st, 2021. It's the last day that you can attest, so make sure you start attesting now and pulling all your documents together and putting them in the EPIP system as you start to attest for your providers to make sure you're able to receive your payments for program year 2020 and program year 2021. So again, October 31st, both program years close. There's not going to be an extension on that, so make sure you attest on time and get all your documents in. If you have any questions or run across any issues, definitely feel free to reach out to Access. Next question. So have you already or do you plan to attest for program year 2020? Text A for yes, B for no, C for unsure, or D for not applicable. So if you're testing for one of the providers at your practice, go ahead and put yes. If you're testing for yourself, go ahead and put yes, or if applicable, you can put no as well if you will not be attesting for program year 2020. Definitely, if you'll have questions on whether the providers are meeting the requirements for program year 2020, you can definitely ask us any questions on this call to discuss those. Okay, it looks like the majority of you are saying no or unsure, so most likely you do need to check the requirements, see if your provider is meeting those, and then if you do have questions, feel free to ask Access or Health Current. Move on to the next question. This is very similar. Have you already or do you plan to attest for program year 2021? So that's the last program year that you can receive money, and that is currently open right now on EPIP, so you want to go ahead and start attesting for your providers if they're meeting the requirements. Give you a few more seconds to put your responses in for that. Okay, we'll move on to the next question. Just keep in mind that program years 2020 and 2021 do close on October 31st of this year, and there will not be any extensions. So make sure you're attesting early and getting all your documentation together to submit. Okay, so the next question is, what is your biggest concern attesting to program year 2021? And this can be for program year 2020 as well if you have a concern for that program year. I know as we get later and later into each program year, there's definitely some concerns as it gets harder and harder for stage 3. For this, when you're responding to the poll, you can just type in anything, so you can text any comment, whether it be a sentence or just a few words, explain what your biggest concern is, and just click send. Any concerns you have, you can bring them up here, or we can discuss them as well. If you have any questions, specific questions, you can definitely put them in the chat box. I see that someone said not having all the necessary documentation available. That is definitely very true. So as you're starting to attest, and if you have a concern, talking to your IT team, if they're the ones in control of the security risk analysis, which is objective 1, definitely reach out to Access and explain your concerns and see what can be done. Definitely try to get a timeline on when you might receive that security risk analysis. That's just one example of not having all the necessary documentation available. Definitely since attestations do close on October 31st this year. Another huge concern, of course, is that providers aren't meeting their standards. That is a concern because there are those minimum thresholds for the percentage-based measures. There's a yes-no requirement. So just start looking at your provider's documentation now, and if you do have some concerns or you think they may meet but you're not positive meet the requirements, feel free to reach out to Access, and they want to help you as much as possible and to make it as smooth as possible when attesting for program years 2020 and 2021. So we'll end this question and we'll move on to the next. Again, if any other things pop up or you think of that might be some concerns for your providers and you want to talk about that, feel free to put that in the chat box. Next question. Okay, so what PI program topics would you like to see more of? So if there's any topics that you want covered, definitely feel free to put those in. Same type of response as the previous question. You can put in whatever words you need to in the text message and click send, or on the website, and you can enter it into the blank box. Okay, we'll give you all a few seconds to respond to that. I know we've done numerous webinars in the past on behalf of Access and Health Current, so there are webinars out there for every single objective, and even when it comes to documentation and what types of documents are acceptable. So those are on the Access and Health Current website. So if you do have any questions related specifically to a specific objective, feel free to go to the Access or Health Current website and look at those webinars. They do have them created for each of the program years. So starting in program year 2018, 2019, 2020, 2021, we have individual presentations, and then also FAQs, frequently asked questions, documents, just to kind of help you along in this process and to better understand the program as we moved into stage 3, which was a slightly harder requirements to meet. Doesn't look like there's any other missing topics that y'all would like to see more of. Again, if you have any questions, feel free to put them in the chat box. Let's move on to the next question. And then here, would you like to be contacted for further assistance? If there's any questions or huge concerns that you don't want to bring up on this call, Access and Health Current are more than happy to reach out to you and answer any questions or concerns that you may have. So A for yes, you would like to be contacted for further assistance, B for no, or C for not applicable. Give you just a few seconds to enter those in. Okay, we'll move on to the next question. Access or Health Current will be in touch with those that said yes. Okay, we're going to move on to polling questions for Objective 2, electronic prescribing. True or false? The EP must use the cert when creating the prescription to count towards the numerator. A for true, B for false, C for unsure, or D for not applicable. So true or false? The EP must use the cert when creating the prescription to count towards the numerator. We'll give you about 7 seconds to answer this. Okay, the majority of you were correct. It is true. So the EP must use a cert as the sole means of creating the prescription for it to be considered electronic and included in the numerator of the electronic prescribing measure. All prescriptions, regardless of how they are created, should be included in the denominator for the measure. Next question. Is an EP able to use intermediary networks to convert electronic prescriptions from the cert into a computer-based fax and electronic prescriptions still be included in the numerator? A for yes, B for no, C for unsure, or D not applicable? Okay, so is an EP able to use intermediary networks to convert electronic prescriptions from the cert into a computer-based fax and electronic prescriptions still be included in the numerator? Give you about 5 to 10 more seconds to answer that. Okay. Very complicated question. I'm sure a lot of us do not deal with IT and technology all the time. Most of y'all probably work in the healthcare industry. The correct answer is yes. An EP is allowed to use those intermediary networks that convert electronic prescriptions from the cert into a computer-based fax in order to meet this measure. As long, there is a criteria though, as long as the EP generates electronic prescription and transmits it electronically using the standards of cert to the intermediary network. And this results in a prescription being filled without the need for the EP to communicate the prescription in an alternative manner. You still have to meet those standards set up in the cert to make sure those prescriptions are being sent electronically. So if you have any concerns about this specifically happening to one of your providers, I definitely recommend reaching out to your cert to make sure they're calculating that correctly in the numerator and denominator, and feel free to ask Access any questions that you may have for that. Next question. So is an EP allowed to limit data included in the electronic prescribing measure to only those patients whose records are maintained with cert? A for yes, B for no, C for unsure, or D not applicable? Is an EP allowed to limit data included in the electronic prescribing measure to only those patients whose records are maintained with cert? few more seconds to respond. Okay. So the correct answer is yes. An EP is allowed to limit data included in electronic prescribing measure to only those patients whose records are maintained with Cert, but keep in mind they are not required to do that. So they do get to choose. However, they do need to be consistent when they're calculating and making sure that they're including whichever route they pick. They need to be consistent and go that 100% of the time during that PI reporting period. Next question. If a patient requests a paper prescription, is the EP able to exclude the prescription from the denominator? A for yes, B for no, C for unsure, or D for not applicable? If a patient requests a paper prescription, is the EP able to exclude the prescription from the denominator? A few more seconds to respond. Okay, you all got it right. The correct answer is no. When a patient requests a paper prescription, the EP may not exclude the prescription from the denominator. The denominator includes all prescriptions written by the EP during the PI reporting period. Next question. Can EPs include controlled substances as permissible prescriptions for the measure? A for yes, B for no, C for unsure, or D for not applicable? Can EPs include controlled substances as permissible prescriptions for the measure? Give you about 10 seconds to answer this question. Okay, looks like you all, the correct answer is yes. You all got it right. EPs may choose to include electronic prescribed controlled substances in their permissible prescriptions where feasible and allowable by state and local law. Keep in mind that if an EP chooses to include such prescriptions, he or she must do so uniformly across all patients and across all allowable schedules for the duration of the PI reporting period. Arizona does recommend including controlled substances when reporting the measure if inclusion would not prohibit the provider from meeting the measure. That is a choice that the provider can make on their end. Next question. We will be moving on to polling questions for Objective 3, Clinical Decision Support. So the first question is, what is a clinical decision support, a CDS rule? A, for health IT functionality that builds upon the foundation of an EHR to provide persons involved in care processes with general and person-specific information intelligently filtered and organized at appropriate times to enhance health and healthcare. B is for CDS rules are for interruptive activities in the Cert, such as pop-up alerts. C is that CDS alerts is information displayed or linked in the Cert, such as an info button. D, CDS rules is targeted highlighting of relevant data in the Cert. E, all of the above. F, unsure, or G, not applicable. That was a lot of information, so I'm going to give you all about 15 to 20 seconds on this question to respond. Keep in mind that A is for the first health IT functionality that builds upon the foundation of the EHR to improve the person's health care. B is for interruptive activities in the Cert, such as pop-up alerts. C is information displayed or linked in the Cert, for example, an info button, information button. D is targeted highlighting of relevant data in the Cert. E is that all of the above are true and represent what a clinical decision support rule is. F for unsure, or G, not applicable. Give you about 5 more seconds to pick an answer. Okay, the correct answer is all of the above. So all of these things are clinical decision support rules. It is a health IT functionality that builds upon the foundation of the EHR, which is A. It is B because it's interruptive activity in the Cert, so it's a pop-up alert. For example, if a patient has a high BMI, it may pop up that they have a high BMI. So keep in mind that that can be an example of a CDS alert. Also, it's information displayed or linked in the Cert, such as the information button. So if that BMI thing pops up, or if it's just in the patient's chart, there may be, click on this button for more information regarding this health concern. D, it is a targeted highlighting of relevant data in the cert, so it could pop up in red, the BMI for that patient, so it's alerting that provider, catching the provider's eye. So essentially, it's anything that's going to help improve the patient's health care, and also alerting that provider that there's additional information out there, or there's a concern with the patient's numbers when they're being seen by their provider. Next question. When should an EP have the CDS interventions used to meet Objective 3, Measure 1 enabled? Select all that apply. A, before the PI reporting period. B, during the PI reporting period. C, after the PI reporting period. D, unsure. Or E, not applicable. Keep in mind, this question does allow for multiple answers, so definitely select all the ones that you think apply. So when should EP have the CDS interventions used to meet Objective 3, Measure 1 enabled? Select all that apply. Give you about 10 seconds here to respond. Okay. So it looks like we have a variety of responses. Numbers A and B are correct. The CDS interventions, there needs to be 5 of them turned on to meet Objective 3, Measure 1. They should be enabled prior to or during the PI reporting period. The same interventions do not have to be implemented for the entire PI reporting period as long as the threshold of 5 is maintained for the duration of the PI reporting period. So keep in mind, you should be turning on those CDS alerts before or during the reporting period. If you turn them on afterwards, that's not going to support that you met the measure during the PI reporting period. EP should implement the CDS interventions at a relevant point in clinical workflows when the intervention can influence clinical decision-making before diagnostic or treatment action is taken in response to the intervention. Next question. Do all 5 CDS interventions have to be related to ECQM, which is Objective 3, Measure 1 still? So we're still talking about those clinical decision support rules. A for yes, B for no, C for unsure, or D for not applicable. Do all 5 CDS interventions have to be related to ECQM? Give you about 10 seconds to respond. Okay. The correct answer is no. So not all CDS interventions have to be related to ECQMs. However, to qualify for this measure, an EP must implement 5 CDS interventions related to 4 or more ECQMs at a relevant point in patient care for the entire PI reporting period. So 4 of those CDS rules need to be related to different CQMs. However, not all 5 of them have to be related to CQM. Next slide. Looks like we're having just a little bit of connection issue. Oh, we're back. So that's the next question. Is going to be, is an EP able to count drug-drug and drug-allergy interactions as one of the 5 CDS interventions? A for yes, B for no, C for unsure, or D for not applicable. Give you about 10 seconds to respond to this one. Is an EP able to count drug-drug and drug-allergy interactions as one of the 5 CDS interventions? A for yes, B for no, C for unsure, or D for not applicable. Give me a few more seconds to respond to that one. Okay. The correct answer is no. An EP is not able to count drug-drug and drug-allergy interaction checks as one of the 5 CDS interventions. Drug-drug and drug-allergy interactions is Objective 3, Measure 2. And so they must have, that's its own requirement. So one of your 5 CDS rules is not allowed to be drug-drug or drug-allergy interactions. Next slide. So we're going to move on to Objective 4, Computerized Provider Order Entry. So the first question is, what is a computerized provider order entry, otherwise known as CPOE? A, CPOE is providers use a computer assistant to directly enter medical orders, for example, medications, consultations with other providers, laboratory services, imaging studies, and other auxiliary services from a computer or mobile device. B, is CPOE the entry of the order into the patient's EHR that uses a specific function of Cert. CPOE does not otherwise specify how the order is filled or otherwise carried out. C is for all the above. D is for unsure. E is for not applicable. So what do you consider a CPOE? Please answer appropriately. Give you a few more seconds to respond.
Okay, the correct question is C. It's all of the above. So definitely, so when it comes to entering in those computerized provider order entries, this is to help to move things electronically and to be reporting electronically those medication, laboratory, and radiology orders into the Cert. Next question. Is an EP allowed to limit data included in the CPOE measure to only those patients whose records are maintained with Cert? A for yes, B for no, C for unsure, or D for not applicable. Is an EP allowed to limit data included in the CPOE measure to only those patients whose records are maintained with Cert? Give you about 7 seconds to answer this question. Okay, you are correct. So an EP is permitted but not required to limit the measure of this objective to those patients whose records are maintained using Cert. Okay, so they don't have to, but they can if they want. Just make sure, they need to make sure that they're being consistent. Next question. True or false, to count in the numerator, the CPOE function must be used to create the first record of the order that becomes part of the patient's medical record and before any action can be taken in the order. A for true, B for false, C for unsure, D for not applicable. So true or false, to count in the numerator, the CPOE function must be used to create the first record of the order that becomes part of the patient's medical record and before any action can be taken on the order. Give you about 10 seconds to answer this one. Okay, you are all correct. It is true. So, for example, if a patient is seen twice during the PI reporting period and the CPOE function was only used on the second visit, but not the first visit, the patient would not be counted in the numerator. Keep in mind there are a few very rare exceptions, and that is covered in the FAQ for our presentation on CPOE. So if you do have additional questions about that, feel free to reach out to Access and we can discuss those options with you. But best practice would be to enter in all CPOE orders into the Cert every time you see the patient, just making sure that you do that and you're consistent using the Cert. If you have any questions about that, definitely feel free to put them in the chat box. Next question. And so we do only have a few questions left, so just keep in mind that if y'all do have any questions or would like to be unmuted, please go ahead and put that in the chat box and we can definitely discuss any concerns you have with the testing to program years 2020, 2021, or anything about the Promoting Interoperability program. So our next question is, can the EP choose to exclude orders that are predetermined for a given set of patient characteristics or for a given procedure, which is also known as protocol or standing orders, from the calculation of CPOE numerators and denominators? A for yes, B for no, C for unsure, or D for not applicable. So can the EP choose to exclude orders that are predetermined for a given set of patient characteristics or for a given procedure, which can also be known as protocol or standing orders, from the calculation of CPOE numerators and denominators? Okay, so then can the EP choose? A for yes, B for no, C for unsure, or D for not applicable. Okay, give you about 7 more seconds to respond. The correct answer is yes. So the EP can choose to exclude those orders that are predetermined for a given set of patient characteristics. So, for example, if a patient comes in and they have a high BMI, there's like certain specific things that the Cert will do in place to certain characteristics that they'll say, okay, let's do this. Like this is a protocol to practice. So basically, the question is asking, can the EP choose to exclude those orders? So if they are automatically given a specific medication order, can they choose to exclude that from the numerator and denominator? The EP can choose to do that. They're not required to, though, but they need to be consistent for all 3 measures, for medication orders, laboratory orders, and radiology. So if they choose to exclude those protocols or standing orders, if they choose to exclude those, they need to exclude them from all 3 measures in the numerators and the denominators. But if they choose to keep them in there, they can, but that's their choice. So definitely as you're looking through your Cert dashboards to see whether your providers are meeting those requirements, that is another thing that you can look at to see if that would help the provider meet the minimum threshold. If you do have any specific questions about that, we can definitely talk about that. You can put your questions in the chat box, or down the road, you're testing in a couple weeks, feel free to reach out to Access and we can help walk you through that scenario if that does occur. So if you have any questions, definitely let us know. Next slide. And I believe that is all the questions, the polling questions that we have for today. So we do have 14 minutes left in today's presentation. So if you have any questions, definitely feel free to put them in the chat box or even request to be unmuted, and we can answer any questions or concerns that you have. This slide just goes over the future webinars. There's only 2 webinars left, and they're both open forums. If you have questions during that time, feel free to join us for the webinar, and we can answer any questions that you have. The next webinar that's coming up is September 16th. It's for the documentation and program closure. So again, it'll be highlighting those dates and potentially going over documentation that may be considered sufficient for that you should be submitting in EPIP. So if you have any questions about that, definitely feel free to ask them now or bring them to that webinar. The last webinar is going to be focused on post-pay and the possibility of when audits occur and what are those best practices. And that is going to be on September 30th. So definitely make sure to register for both of those webinars. Next slide. This slide just goes over the contact information for Arizona State Immunization Information System. So if you have any concerns with your provider meeting the immunization and registry and submitting public health data to them, you can feel free to reach them via email or phone. Same thing goes for the electronic laboratory reporting, syndromic surveillance, and the Arizona Cancer Registry. So all 4 of those departments do relate to the public health registry, which is Objective 8 for when providers submit public health data. The other contact information listed on here is for Access for the PI program. There's an email as well as a phone number for them, and also listed for Health Current as well. So if you have any questions as you're starting to attest to either Program Years 2020, 2021, or just questions about the program in general, feel free to reach out to any of the agencies listed on this slide. Next slide. We do have some time left, so if you have any questions, please feel free to request us to unmute your line or put them in the chat box.
Thank you so much, Priscilla. If you raise your hand, I'm happy to unmute anyone at this time. If you have questions, as Priscilla had mentioned, please put them in the chat box and we'll go ahead and read those and get your questions answered. And I'll go back 1 slide just so we'll hold the contact information here for anyone that needs it. These slides will be sent out again as a reminder to everyone who participated today. And you can also watch the video once it's posted up on the Access and Health Current websites. So I'm not seeing any questions come through or folks, looking to raise their hand at all and ask to come off mute. It looks like folks are starting to exit out of today's webinar. We'll hold you for just another minute or two here. But while we're doing that, I just want to thank everyone for your time today and any questions or comments that you had. Each of you who have registered and participated in the open forum, again, will receive a copy of today's slide deck and any Q&A addressed during the call. The call has been recorded and will be posted along with the Q&As and any other subject matter documents specific to today's open forum to the Health Current and Access websites. Again, this is going to conclude today's open forum. Thank you, Access and Priscilla, for today's presentation and presenting. Thanks to all of you for participating. Have a great and wonderful rest of your day. Thank you.